Well, thanks for having me. I appreciate having the time to speak about the topic. It was probably one of the most difficult talks that I had to put together for a patient audience, because I think that the subject matter can be quite complicated and quite in-depth from a scientific standpoint. So I needed to be able to figure out how to communicate the basics. And I think that it's also a difficult emotional topic from an ovarian cancer patient standpoint to deal with recurrence. We're not going to kind of focus on the emotional or social aspects of recurrence. We're going to more be focusing on the medical or the scientific aspects of it. So some statistics that I think we probably all know. See? There we go. So it's the most lethal GYN malignancy, epithelial ovarian cancer, accounting for approximately 14,000 deaths annually. Unfortunately, because the disease is difficult to diagnose, because symptoms can be somewhat subtle, 75% of patients present with advanced stage disease, that's stage 3 and 4. 70 to 80% of patients, however, will respond to chemotherapy, which is very, very different to some other types of cancers we take care of as oncologists, lung, for example, or colon, pancreas. They tend not to respond as dramatically to chemotherapy as ovarian cancer does. 60% of patients, however, with advanced stage disease will experience a recurrence. So after being informed of a recurrence, patients kind of describe a feeling of living in limbo. They feel that they've been denied their future, and they're simultaneously hoping to be able to delay the advancement of cancer. And that's, as an oncologist, that's what we're here to do. We're here to provide patients with the tools that are available to us to prolong their life and to provide a decent quality of life while we're prolonging that life. Some of the other feelings that patients feel, they're kind of living on the threshold of the unknown. They don't have a lot of information about what to do about their recurrence. They feel a little bit dissociated from themselves and things around them. And some patients actually even feel responsible. I have to tell you, I hear that question over and over and over again. What did I do wrong? And I think that's just human nature. We feel that if we play by the rules and we do what we're asked to do, and we kind of jump through all the hoops that our physicians have asked us to, to do, then why do I have recurrence? It must be something I did. So obviously with first-line therapy, so when a patient presents initially with the diagnosis, the goal is to cure the patient, to provide the patient with a long-standing survival. Cancer never comes back. Therefore, when we're treating somebody initially for that cure, our acceptance of toxicity is quite high. We will accept, meaning the doctor will accept, and more importantly, the patient will accept a high level of toxicity if the payoff is there for them. So if the payoff means a cure and survival, then they're willing to accept a fair amount of toxicity. Convenience is less important when you're dealing with patients who are initially treated for ovarian cancer. The goals of care for recurrent cancer are quite different. They are often defined by the status of the disease. So how long did it take since the previous treatment to recurrence? What is the volume of recurrence? So how much tumor is present with the recurrence? And where is the recurrence? Is the recurrence intra-abdominally? And if so, how many points in the abdomen are involved? What structures in the abdomen are involved? Or is the recurrence distant? Are there lung or liver mets? It's also, goals are defined by the patient. What toxicity will the patient accept, knowing that the options that we have for treatment of recurrence will not offer a long-term cure. They may prevent the disease from progressing, and that prevention may add years and years to the patient's life, but ultimately, right now, will unlikely provide a cure. And then the patient has to take into the lost time in terms of travel to be treated, some of the inconveniences, resources that they have to kind of put out there in order to obtain their treatment. So, for example, we see patients in Erie, we see patients in Northwest, Johnstown, Latrobe. There are things that those patients want to participate in from a clinical trial standpoint. What are those patients willing to do to travel to Magee or Passavant or to another cancer site that may be providing them with a clinical trial that is not available to them in their home? And that's 3 or 4 hours in the car, back and forth every 2 to 3 weeks. And the patient has to make a decision as to whether they feel that they want to make that investment, that they want to rise to that type of challenge. Some questions for the physician to define in terms of recurrence are: what options are reasonable? Clinical trials that are available. Questions for the patient: lifestyle choices. What symptoms are they experiencing from their recurrence at that particular time? And what are the side effects of the treatment that they're going to be getting for their recurrence? I thought it was important to talk about some definitions because patients with recurrence are often confronted with physicians, and I am guilty of this too, who kind of throw things around in the office assuming that patients really know what we're talking about. And so there's some basic things that I think all patients who have been diagnosed with ovarian cancer, they need to understand the lingo. So when we talk about platinum-sensitive ovarian cancer or platinum-sensitive disease, these are recurrences, patients who recur greater than 6 months following their completion of their initial platinum therapy are considered platinum-sensitive. That means they are likely to respond to another platinum-based therapy at the time of their relapse, either with a single agent platinum, either cisplatin or carboplatin, or a combination containing platinum, Taxol and platinum, or gemcitabine and platinum. Platinum-resistant disease, patients who are patients who recur outside of 6 months following their initial treatment with platinum-based therapy. And generally, we would treat those patients with a non-platinum agent. Doxil is one of the agents we use with overall response rates. And an overall response rate means a partial response, a complete response. It's any response that is seen in a patient, whether that's a minimal response or a complete response. It's all lumped together. That's 26%. Retreatment with Taxol, 30% response rates. Gemcitabine, 16%. Topotecan and etoposide, response rates of 12 to 14%, and Navalbine, 21%. Very, very, very hard to have the patient or to kind of steer patients away of kind of focusing on those percentages. And I emphasize to all patients that percentages are really what we use as clinicians to try to make decisions about what agent we are going to use. A patient shouldn't look at that percentage and say, well, does that mean I'm only going to have a 15% chance of responding? That is true, but it's also true that she could have double that type of response rate with that particular agent. So I try to encourage people to look beyond the percentages, but they're important because they're what we use to triage and to try to decide what to offer patients, in addition to what type of side effect profile those drugs have. Finally, platinum refractory disease are individuals who experience progression of cancer during initial therapy. So during those first 6 cycles of Taxol and carboplatin, let's say after the 4th cycle we find that the CA-125 rises unexpectedly. That patient is demonstrating a platinum refractory disease. And then briefly, these are things, these 3 definitions are what we will often see in papers that compare different types of chemotherapy for recurrence. Progression-free survival is the length of time a patient does not demonstrate progression when on a particular drug. Overall survival is exactly what it says, the overall survival of the patient, how long that patient lives before she dies of her disease. And progression-free interval means what is the interval of time between when you start the drug, for recurrence when the patient demonstrates that she's progressed on that particular drug. It's the third thing that is used, progression-free interval is used as a surrogate for predicting response to chemotherapy. It's what we use as clinicians to compare drugs. What do we consider a CA-125 as? How do we decide whether a CA-125 shows progression or not? And there are two types of patients. There's patients whose CA-125 normalizes after treatment. And basically, a patient will demonstrate progression if a CA-125 level is at least 2 times the upper limit of the normal level on 2 measurements taken at least 1 week apart. The second group of patients are patients whose CA-125 never really normalizes. It comes down, but let's say it comes down to 30 or 40 and stays there. What do we consider progression in those patients? This is something we emphasize to patients all the time. CA-125s will vary. There are all sorts of things that can make them bounce around. So we look for essentially 3 points on a curve in order to make a decision as to whether something's not working, a regimen is not working or not. So how do we diagnose recurrence? This is come up recently. It's an abstract that was published in ASCO in 2009. It actually was published in Lancet. The paper was published in Lancet by Ruskin. And basically what he looked at whether doing CA-125s in a serial fashion really made a difference in terms of whether women lived longer. So does recognition of recurrence by identifying an elevated CA-125 translate into a better survival for patients? So if you identify recurrence 3 months earlier in one patient compared to another, does that translate into an improved survival? And what they found when they looked at about 1,400 patients is that it really doesn't. In fact, when you looked at quality of life, the patients who you did not follow with a serial 125 and who were not started on chemotherapy early, these are asymptomatic patients, so these are patients without symptoms. So patients who you held off on giving chemotherapy to until they became symptomatic actually rated their quality of life better than patients who received CA-125s on a serial basis and identified their recurrence earlier. It's very, very controversial. Many oncologists kind of looked at that and kind of did what they do. You know, they didn't really change their practice in this country. Most GYN oncologists in this country still offer their patients either monthly or CA-125s at 3-month intervals. I can tell you why I do that in a minute. Some of it is patient-generated, some of it is academic, and some of it is practical. Some of the practical reasons to follow CA-125, and I just throw this out as an example. There is evidence that in patients with platinum-sensitive disease, detection of asymptomatic recurrences is associated with a higher likelihood of optimal secondary cytoreduction and extended post-recurrence and overall survival. What does that mean? That means if you identify a recurrence earlier by CA-125 and you go back and you redebulk those patients or reoperate on those patients, you're going to be more successful in doing that if you identify the recurrence earlier than if you didn't, if you waited for them to become symptomatic. In fact, another paper showed that with every week of delay, there is about a 3% rise in the chance of a suboptimal secondary resection. So that is an example as to why I think I would not walk away from monthly or CA-125s at 3-month intervals. I also think you have to kind of look at the social context sometimes where these studies were done. I believe I believe that study was done in England. They have a different health system, and they have different socioeconomic pressures. Briefly wanted to touch on chemosensitivity assays because that's something that we will often use in patients who have recurrence. We will either send fluid from the chest or the abdomen to see if we can grow those cells and then expose those cells to certain types of chemotherapy to see what they're most sensitive to. Holly Gallion, who was a member of this division in the, I think, 2004, 2005, actually worked closely with Precision Therapeutics, which is a company based in Pittsburgh, and she showed a threefold increase in the progression-free interval of patients treated with a drug that was tested as responsive to chemotherapy compared to those treated with a non-responsive drug. On the other hand, an independent panel organized by ASCO in 2004 kind of countered that. And their statement is the following: the use of chemotherapy sensitivity and resistance assays to select chemotherapeutic agents for individual patients is not recommended outside of the clinical trial setting. Oncologists should make chemotherapy treatment recommendations on the basis of published reports of clinical trials and on patients' health status treatment preferences. Who's right? I think they're both right. I think there is something to be said for continuing to investigate chemosensitivity assays by providing that data to patients and also by banking that data. Working in an academic center, I think that by sending that tissue for sensitivity assays, we are really going to be able to mine a lot of data by retrospectively looking back on that and maybe, hopefully, come to some better conclusions as to how to use those assays to help manage patients. In addition, there are many, many, many more molecular studies that not only look at the sensitivity of tumors to chemotherapy, but also look at how individual tumors handle chemotherapy. So you can have one woman with ovarian cancer and another woman with the same ovarian cancer. They look histologically similar under the microscope, but from a molecular standpoint, they are totally different. They handle chemotherapy totally differently. One may be chemoresistant based on certain genes, and one may be chemosensitive based on certain genes. That genetic profile is going to be important in the future, I think, because you're going to be able to then dictate more closely or respond more closely to a patient's individual tumor as opposed to grouping people into large histologic groups. So what are the treatment options for recurrence? We touched briefly on secondary cytoreduction, in other words, going back and removing the tumor that's recurred. We'll get into that a little bit later. Retreatment with a platinum or a taxane. Second-line therapies, radiation therapy, immunologic gene therapies, intraperitoneal therapy, and hyperthermic chemotherapy. For platinum-sensitive disease, again, what we tend to use in patients who recur outside of 6 months is a platinum-based therapy, either single-agent platinum or combination therapy. The interval, or the platinum-free interval, in other words, what the length of time is between when a patient was last treated with platinum to when you reintroduce it, makes a difference in terms of patient's response. So you can see in both graphs, if a patient responds anywhere between 13 and 24 months, 33% response rate to platinum. But in both studies, one by Markman and one by Gore, almost doubled response rate in patients who recurred outside of 24 months. What about for refractory disease? Again, secondary cytoreduction, combination chemotherapy, non-platinum agents such as Doxil, gemcitabine, and Avastin or bevacizumab. I'm going to run through and touch very briefly on some treatment options for recurrence. Certainly, there are new chemotherapeutic agents that are coming to the fore every year. Trabectedin was originally derived from the sea squirt and is now synthetic. It's a very interesting drug. In the 1960s and 70s, I believe the U.S. government looked at chemicals derived from animals in the ocean, and they found that this particular chemical from this particular animal had anti-tumor characteristics, but you needed such a tremendous amount of it to actually make the drug that I think it was something like 5,000 animals in order to get 5 grams of drug, something ridiculous like that. So the whole idea kind of sat on the shelf until 1996, when somebody went back and they actually made the synthetic molecule to the natural molecule. And now it is being tested and being paired with drugs such as Doxil. Basically, it binds to DNA and interferes with the cell's ability to repair DNA and therefore causes cell death. There's a new formulation of Taxol, and it's basically taking Taxol and incorporating it into a very small molecule, surrounding that surrounding Taxol with albumin. And what that's allowed us to do is to administer the drug without all those hypersensitivity drugs that we give, pre-medication that we give for Taxol, so we can avoid using Decadron and Benadryl and all those drugs that can wreak havoc with patients' blood sugars. And we also are better able to give that drug weekly because that drug is surrounded by albumin. It's kind of cushioned in albumin. It's also allowed us to concentrate the drug in tissues more effectively. So those are two examples of how we're taking, one is an example of a new chemotherapeutic agent, and another is taking a chemotherapeutic agent that's been around since the late 90s and making it better. Certainly, treatment options in terms of immunotherapy, there are certain proteins or antigens that are created by tumors, CA125, TAG72, and with immunotherapy, we're making antibodies against these abnormal proteins and therefore eliminating tumor cells by having the antibodies attached to them. Cytokine therapy. Cytokines are proteins that stimulate an immune response, such as IL-2 and GM-CSF. And hormonal therapy. Tamoxifen is a drug that we sometimes use for ovarian cancer. Response rates are relatively low, but we really don't have any good studies comparing tamoxifen to standard second-line chemotherapies. Another drug that's an oral, is administered orally, are the PARP inhibitors. You may have heard those for patients who are BRCA1 and 2 positive. Basically, it inhibits a protein that causes the BRCA1 dysfunctional cell to die. And we've seen overall response rates of 33%. This is a relatively well-tolerated drug. It's administered orally. And if you compare that to some of the other IV medications, that's a pretty significant response rate for a drug with few side effects that you can take by mouth. 38% response rates in platinum-sensitive disease, 30% rates in platinum resistance. And it may, in the future, be used for women who are not BRCA1 or 2 positive, who just have somatic mutations that caused the ovarian cancer. So no talk of recurrence would be complete unless we touched on Avastin or bevacizumab. It's a humanized monoclonal antibody which interferes with the binding of vascular endothelial growth factor to its receptors. Basically, it impairs the tumor's ability to make blood vessels. The GOG did a study that showed a clinical response using it as a single agent of 21%. And we're looking at pairing Avastin with other drugs that we use for second-line treatment, such as Doxil, topotecan, and Taxol. Some of the things that we always touch on when we offer patients with recurrence Avastin, certainly Avastin is not a benign drug. It's something that can cause significant side effects, malignant hypertension, thromboembolic disease, and probably more importantly for the ovarian cancer patient, bowel complications. In fact, bowel complications with the use of Avastin are more common than any other cancer where Avastin is used. Even colorectal cancer, where you think you'd have a lot of bowel complications, ovarian cancer demonstrates a higher perforation rate than any other, with rates ranging anywhere between 0 and 11% and 0 to 9% in patients who use Avastin in combination with another therapy. We know that bowel complications for the use of Avastin are related to the number of treatments or number of therapies the patient has before. So a patient who's been heavily pretreated with other drugs, has gone through a multitude of second-line agents, has a higher risk of bowel perforation. Patients who have bowel involvement on CT, so either bowel wall thickening, bowel obstruction, or nodules in the rectum when you do your exam when you do your pelvic exam, all of these patients have a higher risk of perforation. Now, perforation is not a benign thing. In fact, the handful of patients that I've had in my career who've had perforations from Avastin have done very poorly. In fact, the 30-day mortality rate following a perforation associated with Avastin is 50%, which is really very, very high. So it's a drug that holds tremendous promise. It's a drug that recently has been demonstrated to show a survival benefit when used up front, or in other words, with initial therapy for ovarian cancer coupled with standard chemotherapy. But it's a drug that has to be used with a lot of thought. The patient has to be well informed of potential risks. So as a surgeon, I wanted to kind of end towards, or at least touch upon, the surgical treatment of recurrence. And right now we don't have any phase 3 data. In other words, taking patients and comparing groups head-to-head, randomizing patients between patients who receive surgery for recurrence versus patients who don't. We have retrospective data, in other words, data looking back onto patients. That data is generally not as reliable. So we don't have any level 1 evidence to demonstrate a survival advantage associated with a second cytoreduction in women with recurrence. However, we do have a lot of retrospective data that suggests the benefit. The caveat is that unless you can remove all of the gross disease, so unless you can remove all of it, there's very little benefit to it. So patients where you leave residual disease greater than a centimeter or 1 to 10 millimeters, there's no difference in survival. The impact on survival is seen in women who you can completely resect all visible disease. Now, how do you decide whether to go back on somebody? How do I decide whether to offer somebody a secondary reduction? And number one, the patient really, in my opinion, should be sensitive to platinum. So they should have recurred well outside of 6 months. If they recur within 6 months, that demonstrates that they generally have a tumor that is refractory to all chemotherapy. So why put the patient through a big surgery with a lot of morbidity and at least theoretically a small mortality rate if you don't have anything to give her as follow-up from a chemotherapy standpoint? Because she's going to be right back in the position she was very quickly if you don't have any chemotherapy options for her. So number one, the patient has to be platinum sensitive. Number two, she has to have a decent performance status. So a few health problems, relatively young age. CT scan has to demonstrate a lesion that you can resect. So if you've got an inoperable tumor in the porta hepatis of the liver, that patient is really not a candidate for resection. So it's got to be resectable, relatively isolated. If you've got diffuse involvement of all bowel surfaces, you're not going to be able to remove it all. And again, the important point to remember is unless you can confidently go in and say, I think I have a pretty good shot of removing all gross disease, I tend not to really put that out there for patients outside of a clinical trial. The variables that we look at or that we know that impact on resectability are the initial stage, how much residual disease was left after the first surgery, what the progression-free interval was, as we just discussed, the performance status of the patient, her CA-125 at the time of recurrence, and whether there's evidence of ascites at the time of recurrence. I briefly wanted to talk about hyperthermic chemotherapy because I think it's an exciting possibility not only for patients who initially present with ovarian cancer, but also patients with recurrence. Basically, what you're trying to attempt to do with any type of intraperitoneal chemotherapy, but particularly hyperthermic chemotherapy, is you're trying to provide the tumor with or expose the tumor to higher drug concentrations. Hyperthermia, or heat in and of itself, has direct cytotoxic effect or direct cell killing effect, and we know that hyperthermia has a synergistic effect with some chemotherapies such as oxaliplatin. It's been proven by many centers, particularly here at the University of Pittsburgh, Hillman Center with Dr. Dave Bartlett, to have an acceptable morbidity and mortality. But there is a definite need for prospective randomized trials. So again, if a patient is interested in seeing one of our surgical oncology colleagues regarding hyperthermic chemotherapy, I would say that the same things kind of apply. They have to have a relatively good performance status. You have to have some idea on CT scan that their disease is resectable before you offer somebody something. They also have to be, I would say, they have to be platinum sensitive. And this is just a graph showing survival curves of patients who are platinum sensitive versus platinum resistant. So the upper curve, those patients did better with hyperthermic chemotherapy than patients with tumors that were generally resistant to chemotherapy. So I will stop there, and I'll be happy to take some questions. It's an excellent question, because we see it when patients are put on it initially, and we see it way, way down the road. So you can have a patient on Avastin for a year. In fact, I often think of this patient because she had recurrence and had been through multiple regimens for second-line treatment. Finally was treated with Avastin and carboplatin and had a miraculous response. She had a tumor in her pelvis the size of a football. And 1 month it was there, and the next month it was gone. And she was on it for a year. And she had no ascites. She took that year, and she traveled all over the world with her family. I mean, she went everywhere and had the most fantastic year imaginable and was doing quite well. And then came back, had no evidence of disease. So she had a CAT scan that was negative. A week later, she comes in with a perforation and died of that perforation. The symptoms of a perforation are abdominal pain, fever. Bowel perforation is a surgical, is a catastrophic event normally. It's like it's worse than having a ruptured diverticulum, because a ruptured diverticulum will often seal over, or you'll have a portion of healthy bowel seal off. Perforations generally from Avastin are large, with the ensuing problems that you would see with perforation, sepsis, intra-abdominal infection, etc. No, I'm glad you brought that up, because I wanted to touch on that a little bit more. I think that there is value to, you have to ask. What I do is I try to talk to the patient individually. I'll say, okay, well, you're done with your therapy. Here's what we can do. We can check your CA-125 monthly. We can check it every 3 months. We can not check it at all. And I will kind of touch on some of the data that has been kind of put out there within the last couple of years. I think there's a psychological component to this and a emotional component to knowing your disease status as a cancer patient. I think it's a little bit paternalistic of us to say, well, we're not going to do it because it really doesn't help us, or doesn't help you as the patient. But I do think that it helps women to understand where they stand. And everybody's different. I mean, there's some people that say, no, and this is a rarity, but there's some women that say, well, I'd rather not know, and if I have a problem, I'll let you know. And then you've got people that need it every month, and people that say, well, I'll check it right before I come see you every 3 months. So I don't think there's a right answer. In terms of who I image, generally I'll get a baseline CAT scan when I complete therapy in somebody with advanced disease, so I understand from an imaging perspective what they look like at time 0. It allows me to, if they complain of something 6 months from now, or if I have a bump in her CA-125, it's much easier by CAT scan to identify a subtle change if you've got a CAT scan that you compare it to at time 0. So if you didn't get that initial CAT scan at the end of therapy, you'd have nothing to compare it to. So if there was a subtle difference, you wouldn't know it. So generally, the answer to your question is generally with CA-125's baseline CAT scan at the completion of therapy. Certainly any symptoms, change in bowel or bladder habits, distension, nausea, anything different, that patient's going to be imaged, regardless of what her CA-125 is. I think being in close proximity to the University of Pittsburgh and having access to all the things that an academic center can offer, I think that the identification of an early recurrence could benefit that patient, because there are phase 1 and phase 2 trials that are ongoing at the Hillman Center all the time, that you may be, or the patient may be eligible for if she's identified that recurrence, or if the physician's identified the recurrence. I also brought up the issue of surgical resection. So you're going to be more successful at surgical resection second time around the earlier you identify your recurrence. I think if you look at the numbers, that's a pretty large study, close to 1,500 people or 1,500 patients. There really wasn't an impact on survival. But again, I think there are other reasons why it's valid to look at that. But as we go on, I mean, you're going to be seeing a lot of pressure, governmental pressure, on physicians and patients to really say, and this is maybe a perfect example, you're going to have the government saying, well, you know what? We don't have any data to show us that a CA-125 impacts on survival. So guess what? We're not going to pay for it anymore. They're already not paying for Pap smears at 3-month intervals for uterine cancer or for cervix cancer. So you're going to be seeing more and more of this type of thing as patients. Going to be very frustrating for all of us. It is. You can get fistulas with Avastin as well, but a fistula is kind of a perforation that that connects to hollow entities. So you can have a colorectal, or rather a colovesical fistula, or a fistula between bowel and bladder, let's say. So it's the same principle. It's a hole, but you just got the hole connecting to separate organs. What are the earliest symptoms of a perforation versus a fistula? Well, the symptoms of a fistula are related to, for example, if you had a colovesical fistula, you'd be passing stool through your urine. That's probably the easiest example. As I said before, the symptoms of a perforation are usually abrupt, catastrophic types of symptoms: severe abdominal pain, distension, fever, and patients get sick very, very quickly, and become quite unstable quickly. Question is what the definition of recurrence is, and we get those questions all the time. Well, if I recur in my lung, does that mean I have lung cancer? And sometimes you have to, if you have a patient who recurs way outside of 2 or 3 years, you really do have to make sure that you're dealing with the same cancer. So, for example, if I had a patient with ovarian cancer who had a bump in her CA-125 and had a lung nodule, well, primary lung tumors or lung cancers can make your CA-125 elevated. Patient was a smoker, so how do I know that that recurrence is from ovarian or is a new primary lung cancer? And you don't. And what you need to do is you need to sample that, and you need to compare it to the original pathology from her original surgery. The treatment of recurrent ovarian cancer would be very different than the treatment of a primary lung cancer. So it's important when you're that far out to try to establish a tissue diagnosis. Now, a patient who recurs within 3 months and has, was operated on, had a suboptimal debulking the initial time around, and then 3 months after completing therapy has a new lesion within the abdomen and a bump in her CA-125, I'm not so sure you would need to biopsy that, because it's so unlikely to be something else because of where it is. Most ovarian cancers recur intra-abdominally. They very rarely, I shouldn't say rarely, but they will more prominently recur in the abdomen than they would in the lung or the liver. So that's tough. Well, number one, I still would follow the CA-125 because tumors change over time, and just because she presented initially and did not have a rise in her CA-125 or an elevated doesn't mean that when she recurs she won't. So I'm not sure I would treat her any differently. I probably would do exactly the same. I would follow her symptomatically, I would do a baseline CT scan, and I would follow her CA-125s. You know, I think the sensitivity of a CT is for disease is not what we'd like it to be. So generally you need tumors that are greater than a centimeter to really show on CT scan. I'm not sure that I would want to really be imaging somebody that frequently. I just think that the information gained is probably not worth the inconvenience and the potential side effects of repeat CT scans. That's a philosophical, controversial topic. It's an individual decision. Put it this way, when I have a patient in that scenario, and we all have had them, you really have to have a feel for the patient. I think if it were me or my wife, what would I do? I would encourage her to be treated. Whether that, I don't think that decision is really supported by what we know in the literature. In other words, is that patient's survival going to be any better than if you waited until she became symptomatic or had something on CT scan that you could see? But again, I think it's a complicated issue. I mean, there are people that are quite comfortable with a rising CA-125 as long as they don't need chemotherapy. There's people that say, you know what, doc, I don't want chemotherapy and I feel fine, and I know that I probably got it because my CA-125 has been doubling every 3 months, but I feel fine, my CT scan is negative, I want to hold off. I want to go to the Outer Banks, or I've got a wedding to go to. I really don't want to get involved in chemotherapy. That's okay. I mean, that's the art of oncology, is being able to understand the literature, but also being able to understand your individual patient and guide her based on, you know, her individual wishes. Generally, we do every 3 months for the first 2 years, and then we go to every 3 to 6 months from 3 to 5 years. I generally probably stick to a 3-month regimen throughout my time of having that patient in surveillance. I may see her less frequently. I may see her every 6 months, but I'll give her a prescription for CA-125 every 3. Well, that's a good question. You know, you have patients who, you know, for example, I've had patients on Doxil for a year. You know, they have no evidence of disease, or they've had regression or stable disease. So as an oncologist, what am I happy with when, what is my goal of treating somebody with recurrence? My goal is either stable disease, so a CA-125 that plateaus and stays the same, or a CT scan that demonstrates that whatever we're following nodule-wise or mass-wise is staying the same. Or I'm happy with a dropping CA-125 or a shrinking nodular mass. The only thing I'm not going to be happy with is something that is progressive. So a CA-125 that is rising, or a CT scan that demonstrates that the tumor is getting bigger. Okay, well, I thank you all very much.
Thank you, Dr.
Thanks.